just briefly on the Spark program, which is really consistent, I think, with the overall theme of COPASA. It was really based on an understanding that in our work we needed to engage much more directly with the people who are living in situations of marginalization, their concerns, and finding ways to support their mobilization and their ability to take collective action around these issues. Because we really said, if we get down to the heart of it, it's because people don't matter politically, that they lack political agency, that they are underserved by many of these public services and programs. So that similarly led us, and this is appropriate to this session, to look a little bit deeper when we saw public service gaps affecting marginalized communities, and not just say, well, here's what the gap is from a technical standpoint, or here's why there's not enough resources in the budget, but to continue to look deeper. What are the political economy factors that are playing out here? What are the power dynamics here? So those issues will come up in the context of this conversation.
So turn to your neighbor. This is the person you're going to be spending the next 15, 20 minutes with. Make sure you have a piece of paper as well, because we'd like you to be able to take some notes of your conversation. So thinking now of the role of like some of the issues that Mokera quite cogently put forward as being relevant to how we think about budget analysis and its role in the delivery of services in health. We want you to think about the issue that you work on and define the problem. So just come up with a short statement, 1 to 2 sentences, that articulates what is the problem you're working in and who is affected by that problem. And then what you'd like you to do is have a bit of a discussion with your colleague, compare each other's problem statements. You know, how many of the problem statements are fairly narrow, how many of them are broader? Are there things in the way that the other person has articulated the problem statement that make you think about a different way of articulating your problem statement? So be open to change, to changing how you articulate that. So then the next thing we'd like you to do is to ask, why does the problem exist, right? So there are often 2 to 3, there are often multiple causes. We'd like you to identify the 2 to 3 big causes that you think might be implicating the problem that you're working on. And then once you've identified those, we'd like you to kind of understand a bit more the causes of those causes. So in some cases, those are related to norms and discourses, to power imbalances, to narrow civic spaces, to just the poor administration of budgets that were promised to people and have not been delivered. And there are many underlying factors that could be related to political economy issues, to administrative capacity issues. We'd like you to see how far you can get in terms of identifying what those causes might be. And then, keeping in mind what Mokera had presented, we'd like you to think about the role of public finances. So basically in terms of 2 key questions, the amount of money that's made available, and then how is that money managed? Are there things that you can say as being underlying manifestations of that problem, manifestations of those issues on the problem that you're working on? And then finally, we'd like you to identify what your coalition for change looks like. So there are like-minded groups that you're probably already working with. There are other potential allies, citizen groups, sectoral groups, groups that are potentially not ones that you've forged alliances with, but might be relevant in terms of trying to develop some sort of sense of bargaining power when you think about how do you enter into the arena where some of these decisions get made. And then other potential allies in the broader accountability ecosystem. So here, these aren't necessarily citizen groups or groups that represent coalitions. These are groups that have kind of more societal functions: auditors, media, legal authorities, legislatures, donors to a certain extent. So see what you can do. If you can get through this list in the next 20 minutes with your colleagues.
In IVP Kenya, we say, if you have a great idea, you better know how to implement it. So I did not know this was going to happen to me. Samir just said that it's possible that someone in this room has not necessarily interacted with the public finance space. And so I just wanted to make a few points on what is it we are talking about before we start discussing on how it relates to our work, okay? So I was given like 5 minutes. So I'm going to take 8 minutes to discuss 8 key points on what we are talking about when we talk about public finance and the public finance space or fiscal governance. The first point I want to make is that when we talk about public finance and the budgeting space, we are talking about something that is time-bound. So we are not saying that it can happen anytime we feel as a community it should happen. There are systems that are set in every country on how long, for example, a financial year is, okay? And you have to keep in mind that the budgeting space happens in there are 4 key stages, okay? The 4 key stages are formulation, where we now give our priorities and say this is what we want to do, and then the approval stage, which is usually led by the legislature, and then there is the implementation stage, and finally the evaluation stage, where the audit process comes in as well. So that's a way to think about it, that we're not talking about one calendar year. No. Different countries have different financial years, so you have to go and figure out what is the financial year for your country, when does it start, when does it end, when do the different stages happen, and how can you influence them. The other thing is to say that when we are talking about a budget, it's just like your home budget, that there's revenue coming in and you're spending it. And sometimes you have to borrow, okay? So those are the 3 components. When you have a deficit, you go and borrow. It's the same with governments. They have taxes coming in, and they don't come in as one go. You all know that it comes in at different points. So there's no money kept somewhere that we are going to say that is what the budget, that's a budget that we are currently undertaking. So what we do, when we get to the end of the formulation and approval, we just have estimates. So this is trying to say this is what we'll do in the next year, okay? But we're not saying we already have the money. The money comes within the financial year. So it's about revenue coming in, and then how it's being spent. And how it's being spent is what now we are calling the budget itself. The other point I wanted to make is that the budget is not just about items that we are spending in. It's not about fuel and cars, and it has to have specific objectives. Budgets are not about just buying things and, for the sake of buying. So we have to be clear for the health sector, what are the outcomes that we see the public budget meeting, okay? So when you go to a budget discussion, you're not just discussing build a dispensary here, build a dispensary there. It's what outcomes do we want to achieve? And so from that discussion, we decide how we spend, whether in recurrent or in development. The 4th thing I wanted to say is, these are just 3 principles to keep at the back of our mind. The budget process is not about meeting key dates only, okay? I did say about the timeline, but it's also understanding that at every point, there are key decisions that are being made, okay? And if you don't plug in, the decision is made anyway. So, for example, in the formulation stage, there's a stage where the executive, for example, like in Kenya, which is around this time, will ask people to come and give their priorities so they can be put in planning documents. Because in Kenya, the law says, unless something is in a planning document, it is not implemented, okay? It's not appropriated in the budget. So if you miss to put your priorities in a planning document, which will be the annual development plan, then you can't come back later and say, oh, I missed that part. So there are decisions, there are key decisions being made at every stage, and these decisions are around how we collect, where the money we collect goes. So you have to understand at what point decisions are being made. But these decisions are not just amorphous, they are housed in key budget documents. So go back to your system, try and find out where are the budgets, which documents encapsulate, is that a good word to use? Like which embody the decisions that are key in the process of your country. Then the other thing is just to contextualize whatever it is that we are discussing, finance costs and the recurrent expenditure. So we have to think how the different stages of the budget interrelate, and how the causes of the problems that we are seeing could be sitting in another stage of the budget.
One thing that is standing out is some of these problems are more similar, because we have problems in terms of lack of medicines, as well as poor infrastructure funding. so leading to many health facilities not operational. So which is again cross-cutted around almost the 4 states. And then the issues of poor funding as a reason why it exists is also coming from all of them. Poor prioritization is also coming from all of us. So we can then be able to articulate that some of these challenges and some of these issues are more interrelated. So despite the vastness of or the far ends of the globe, so which means again our strategies, our coalition strategies, can learn from each particular state what's happening and what they're doing. Also learning in terms of the coalitions for change, the 3 states that were here, we talked about civil society organization. Then that's a key anchor in terms of how we can fight for a concerted efforts to ensure that we realize a change that we desire. And then also using of the citizens themselves as a massive power to amass more power that citizens can start championing and fighting for the change they desire.
So we're working on a drinking water issue in our country, the fluoride and arsenic issue in drinking water. So what we find is that it's not only the drinking water department that is responsible for this particular issue. It's also the health department, it's also the nutrition department, it's also, and for example, if it affects young children and women, then it's also the Department of Women and Child Welfare, who can actually be brought into this discussion circle, and then maybe a contribution from each of these particular departments would help in getting the kind of attention that the issue deserves to get it mitigated.
We spoke about a particular issue of directorship positions within the Department of Nursing, and the key gap is mostly the position is filled by doctors in an acting capacity. So the challenge is nurses who have been practicing for a while, the recruitment requirements do not give them the opportunity to apply for that position. So what then effectively means is a doctor comes in and is given an acting allowance. So there's a direct mismatch between now funding that's available for that position. Ideally, it should be held by someone who's for a nursing background. There's a mismatch now between implementation. So over the years, it's just been doctors who have been coming in on an acting position.
Actually, I would like to share you a story of Sathi, because Sathi is working on hardcore health rights. And basically, we are working on the public health system accountability, private health sector regulation, and universal access to healthcare. So we were far from budgets. So it was an interesting journey that hardcore action organization is now working on some part of the budget, and that is we can do, and we got confidence that any organization can work on the budgets, and that is my point I want to share with you. So as you know, in accountability work, if you want to maintain the motivation, the momentum of the activist, momentum of the people, then the issues need to be resolved. And we are working on community-based monitoring and community accountability process. And after some time, we reaches the saturation. And people were saying that, please don't come to us. If you are not helping us in resolving problems or resolving the issues, we don't need you. So in that context, we sit together as a coalition of community-based monitoring, all the civil society organizations, all the like-minded people, and try to analyze what are the issues which are coming from the community action or community accountability process. And we have categorized into 4 to 5 categories. One category was the issues related to the community, and there is a gap between communication gap between community and service providers, like absenteeism, or NM is not going in the village. When she is going, then there is no people or there is no community. So in that context, there should be need to be some dialogue with the community, between community and the service provider. That is one area. There are many issues related to infrastructure, HR, and mostly the issues related to the budget. And here we got the thread of budget. The third issues which require some governance issues. For example, there is a system, but system is not functioning. not giving the service as per norms. So that kind of issue. And the final issues were the systemic issues, policy level issues, budget, human resources, all that. So focusing on the budget, we try to analyze what is the exact problem in the budget issues. For example, we try to understand there is a at each facility there is a committee called Patient Welfare Committee, RKS, Rogi Kalyan Committee in India we call it. And they are receiving some funds from the government and for the welfare of the patient. And we try to, we discuss that where we will get, if you want to resolve the issues which is coming from the community-based monitoring, that need to be some forum or some area where you can chip in. So Rogi Kalyan Samiti, Patients Welfare Committee funds are the area where you can use and you can resolve some issues related to the funds. So we try to analyze what is going on in the Rogi Kalyan Samiti funds, in the Patients Welfare Fund. So we try to find out the fund flow system where we chip in the budget. We try to understand what is last year expenditure, what happened to the last year funds, and based on that funds, we try to develop a planning process. So these kind of small interventions with regards to budget. Then we try to understand what is the budget of at state level, what is the budget of state, what is the budget of, and interestingly we have got some learnings which I would like to share. 1 minute. So one is you just think, you just need to some analytical mind about the budget. In the sense, working on the budget is a political process, and I think if you are clear about what exactly you want to understand in the context of budget, that clarity is very important. Otherwise, you will roam here and there. Second thing, there is no technical as such thing in the budget. What we learned. If you want to raise the issues of the people, then what are their main needs? For example, there is a need of diabetic and hypertension medicines in the community. We ask people, why are you not going to the PSC? They are said, our requirement is a diabetic and hypertension medicines. And in the public health system, they are not providing. So we calculated what is amount required. We means all the people, all the activists, what amount need to be invested to purchase the diabetic and hypertension, and that has been submitted to the government or to the district hospital, and they have allocated funds. So that kind of small thing, it's a very good value addition to the, because when you are arguing with the government or when you are confronting with the government, they ask solutions also. So through the planning process, if you are giving some solution. For example, we asked for, if you want, there is a very contractual appointment of all doctors and all health workers is going on in India. So we tell them, if you want to convert into the regular staff, then this amount you will require. And it's not more than 300 crores. And in Indian context, 300 crores, it's a peanuts in Maharashtra, for the Maharashtra state government. So that kind of key and very valuable insight or valuable evidence you can create through the budget, and that can impact at policy level as well as grassroots level, because budget is it is a very hard to the people. And if you can tell people that this is your village budget, this is your district budget, then people can engage with you.
Quickly, I just want to we're looking at the problem analysis of the primary health care services using Nigeria as an example, the Nigeria context. Though Nigeria is a very huge country, that we have a lot of diversity, a lot of issues when it comes to health-related issues. But I'll talking in perspective of the states where I'm coming from, and then the major issues that are very pertinent in that area. And we've discovered that the issue of maternal mortality rate, which is a general issue, is fine and good, but solutions to that sector is actually very low in our area, and we find out that marginalized communities lack access to basic obstetric services, and which is core. These services is just basically provision of drugs and personnel, drugs like the oxytocin, the personnel when it comes to and you agree with me that majority of our public health centers are absolutely located in the rural areas. About 70% are in the rural areas where we have mostly the women at the family, mostly women and children. And this actually, the facility at that level, the services at that level is absolutely very poor. That it has actually allowed some of the women absolutely now go to the extent of visiting what we call the traditional birth attendants. We call them the TBAs. This actually opened up the space for them to attend that. But for that sector, the government too has no standard or principle that guide their operations. So it's also contributing to the issue of maternal mortality rates in Ogun State and in Nigeria as a whole. So having identified this, like I said, the major set of people that are being affected is the women, most importantly the pregnant women, and absolutely the children also. And we look practically the major issues, root causes of these issues. Number one, Nigeria has a good health policy, a very good health policy. And one of the part of the policy is that 1% of our consolidated revenue fund goes directly to the public health centers. And that is there. But in the last how many years now, that has not been implemented at all. It has not been implemented. So there's a good, so what we are saying that there is a weak implementation of our policy in terms of health policy. Number one, that's number one. Then number two, we have there's what we call the issue of poor management in terms of distribution of drugs, and so there's the mention of resource control, resource allocation is absolutely very poor at that level. It's also one of the causes of this lack of access to. Then the issue of cultural ideology, the issue of culture cannot be overemphasized. That the issue of culture has to still come in place. Some people still believe in the issue of the traditional way. So they still, some must still believe that they still have to go to the traditional man or the traditional woman to have whatever illness or whatever thing that they have. And that's also key in terms of what we are, the issue we are discussing on. And also, like I said, the insufficient political will, absolutely key. For example, in the last 8 years in the States, no allocation has been given to the public health services. No. Allocation has been given to healthcare services, but basically at a secondary and a tertiary level. But allocation for the primary healthcare services is absolutely very, very poor. So the will, because the intention of every political leader is actually signed, the priority, you actually find them in the budget. And if the budget is not speaking to some of these issues, it means that the will is absolutely low. So looking at the budget, the will of in the last 8 years, the political will is absolutely very, 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 very low in terms of public health care services. Very, very low. Very, very low. So these are issues that the communities that we're working with, like we say, we are working with communities. These are the issues that the communities have to, take upon by themselves, take the driver's seats. We at our own end, what we ensure is that the community takes the driver's seats, not the CSOs, not the organized group, but the community drive the process. At our own end, all we need to do is to just, like a catalyst, and ensure that we provide the necessary information to ensure that they can act and they can explore opportunities and opportunities provided for them. So that's basically what we do as CSO. But like I said, that the citizens take the driver's seats. So generally, that's the face of what the issue of the public health services is. Like I said, in the state where I'm coming from, in other states it differs. But the issue of maternal mortality rates is a general thing. like if some of my colleagues states they have issue of water and sanitation issues. We have in other states they have issues of facilities and stuff like that.